All right. Good afternoon, everyone, and thank you for your patience. I think we can start. Welcome to the Department of Medicine Grand Rounds. I'm pleased to present today our speaker, Dr. Cristiana Borjaille. Dr. Borjaille completed her medical degree and her residency training in cardiology and critical care in Brazil. After her residency, she completed 1 year fellowship of critical care in the University of Toronto, and then she subsequently joined us in Hamilton for 2 years fellowship in heart failure at McMaster University. And she is one of our recent recruits as an assistant professor in the Division of Cardiology with great interest in heart failure. Not a surprise, Dr. Borjaille is going to talk to us about the important topic on diagnostic approach in heart failure secondary to non-ischemic cardiomyopathy. Without further ado, I will pass it on to Dr. Borjaille.
Okay, so thank you for inviting me to present at Medical Grants Rounds today. So I'm going to focus this presentation in the diagnostic approach in non-ischemic cardiomyopathy. So this is my acknowledgement and my disclosures. I don't have any any conflict of interest. So the main objectives are to review differential diagnosis in patients with non-ischemic cardiomyopathy, discuss some of the most important cardiomyopathy phenotypes and the diagnostic approach for a definitive etiology, and review general management of cardiomyopathies with focus on some specific etiologies that now we have specific treatment. So heart failure is defined as is characterized by the presence of signs and symptoms of congestion, which is secondary to structural and functional abnormalities of the myocardium. We know that patients with cardiomyopathy, they usually present with heart failure. And we know that the incidence and prevalence in heart failure is increasing all over the world. Approximately 6 million Americans have heart failure, and there is an expectation of this number to rise to 8 million by 2030. So this causes significant increase in costs in healthcare. So that's why it's important for us to try to find a diagnosis and provide the best medical management for these patients. Heart failure is classified according to the LV function. So we classify patients with preserved EF, mildly reduced EF, reduced EF, and now the new classification of heart failure with improved EF that previously was called recovered EF, but now the new nomenclature is heart failure with improved EF. And we also classify those patients according to etiology. Basically, we divide into ischemic etiology and non-ischemic etiology. Ischemic cardiomyopathy is the main cause of heart failure, accounting for almost 30% of patients with heart failure. And in terms of non-ischemic cardiomyopathy, we have a variety of different etiologies. The most common is hypertensive cardiomyopathy, followed by valvular disease and congenital heart disease. But we know that there are different other possible etiologies, including arrhythmias, so tachyarrhythmias that can induce to cardiomyopathy, infective diseases like viral myocarditis, Chagas disease, drug-induced cardiomyopathy, a very important one with specifically chemotherapy-induced, with now the immune checkpoint inhibitors that can cause cardiomyopathy, and not only chemotherapy-induced, but also alcohol-induced and illicit drugs-induced cardiomyopathy. There's also infiltrative diseases like amyloidosis, sarcoidosis, storage disorders, including hemochromatosis and Anderson-Fabry disease, and pericardial disease, autoimmune disease. So there's a lot of etiologies that can cause cardiomyopathy. And all of these etiologies are going to present with different phenotypes. So I want to focus this presentation on the different phenotypes that these patients can present when they have non-ischemic cardiomyopathy. So what is the definition of cardiomyopathy? It's a myocardial disorder when you have evidence of structural and functional abnormalities of the heart in the absence of coronary artery disease, hypertension, valvular disease, and congenital heart disease. Cardiomyopathies can present at any age and can affect individuals in the entire course of their lives. Initially, there was a classification published in 2013 by the World Heart Federation that proposed a classification of cardiomyopathies based on morphology, organ involvement, genetic test, etiology, and functional status. This classification was very detailed, very thorough, but was difficult to apply in clinical practice. And then in 2023, the European Society of Cardiology published a new guideline for cardiomyopathies, describing the different phenotypes based on morphology, function, and tissue characterization. To classify those patients on morphology and functional and tissue characterization is important multimodality imaging. So in terms of morphology, we classify those patients as having ventricular hypertrophy or ventricular dilatation. In terms of the function, we classify them as having systolic dysfunction or diastolic dysfunction. And in terms of tissue characterization, we characterize these patients as having non-ischemic fibrosis or scar tissue or fatty deposition. So they described 5 different phenotypes that are very important to give us some clues in terms of a definitive diagnosis for those patients. The first is the hypertrophic, the HCM phenotype, defined as the presence of an increased alveolar thickness or increased LV mass. Second phenotype is dilated cardiomyopathy, defined as the presence of LV dilatation and systolic dysfunction. There's a new phenotype that was included in this guideline, which is called the non-dilated LV cardiomyopathy, defined as the presence of non-ischemic scar or fatty deposition in patients that have no LV dilatation and no LV dysfunction. So, for example, a patient that comes with symptoms of palpitations or dyspnea, they have an echocardiogram that doesn't show any LV dysfunction or LV dilatation, but when they do a cardiac MRI, there is late gadolinium enhancement in some areas showing that there is non-ischemic scar or fatty deposition. The fourth phenotype is arrhythmogenic right ventricle cardiomyopathy, defined as the presence of RV dilatation and dysfunction, but now we know that these patients may also present involvement of the left ventricle with the presence of ECG changes, fatty replacement on the tissue characterization of the MRI, ventricular arrhythmias, and they usually have a pathogenic variant on the desmosomal protein genes. And the last phenotype is restrictive cardiomyopathy, defined as a restrictive physiology of the left ventricle and the right ventricle, one or both of them, with increased filling pressures and normal or reduced diastolic and systolic volumes. It's important to understand that there is an overlap between these phenotypes. So, for example, patients with amyloidosis, Anderson Fabry disease that have a restrictive physiology, they may present with an HCM phenotype. And if you don't do all the diagnostic pathway, you're not going to do a proper diagnosis and you're not going to find the definitive etiology for those patients. In terms of epidemiology, HCM phenotype is the most common with a prevalence of 0.2%, followed by dilated cardiomyopathy. And considered the rare one is restrictive cardiomyopathy, but now we are diagnosing a lot of patients with cardiac amyloidosis, so this may change. In terms of Canadian populations, we know that there are some genetic cardiomyopathies associated with dilated phenotype. They're present in French Canadians. There is also an increased prevalence of Fabry disease and HCM phenotype in Nova Scotia. And HCM phenotypes with a specific genetic abnormality in Manitoba. Important concepts for us to understand is that previously LV non-compaction was also considered a cardiomyopathy, but because this is a phenotype with prominent LV trabeculations that can be present, isolated, or associated with abnormalities like LV dilatation and LV systolic dysfunction, this is not considered a cardiomyopathy anymore. It can be, like I said, isolated and present in patients, for example, athletes or pregnancy without any genetic abnormality, without any symptoms, without any LV dilatation. So because this is a very heterogeneous and more like a phenotype, it's not characterized in this new classification. The other syndrome, Takotsubo cardiomyopathy or stress cardiomyopathy, is also not considered a cardiomyopathy because of the transient LV dysfunction that is associated in these cases. There is a high concentration of norepinephrine with dilatation, LV dysfunction in the absence of obstructive coronary artery disease. We know that it's usually associated with emotional and physical stress. And because it is transient and the patients usually improve the LV function after the episode, it's not considered a cardiomyopathy. So how do we approach the diagnosis in this patient? So we have a clinical scenario of a patient that comes with symptoms of dyspnea or palpitations or an ECG abnormality, and then we proceed with multimodality imaging because it's important to understand, again, morphology, function, and tissue characterization. After we proceed with the multimodality imaging, we can describe the exact phenotype of those patients. And then we have to also understand the family history of those patients to try to identify Mendelian forms of inheritance. It's also important to do a genetic test that I'm going to talk about it on the next slides. It's also important to find extracardiac involvement. This will give us important clues in terms of the diagnosis of those patients. Blood work and laboratory markers like NT-proBNP, troponin levels, sometimes albumin-creatinine ratio to assess for proteinuria. These are also important for us to try to find the proper diagnosis. And if after this evaluation is still inconclusive and we don't know the etiology, we can always perform an endomyocardial biopsy to find the definitive diagnosis. In terms of multimodality imaging, we can do ECGs, we should do ECGs, echocardiogram, cardiac MRI, PET scan if you suspect of sarcoidosis, pyrophosphate scan if you suspect of amyloidosis. And what I want to focus on this presentation is cardiac MRI, because we know that cardiac MRI is the gold standard modality to assess morphology, function, and tissue characterization. And the cardiac MRI is not important only for diagnosis, but is also important for prognosis and to assess responsiveness to therapy. So we know that with cardiac MRI, with the new sequences quantifying T1 mapping, T2, T-weighted relaxation times, we can try to find a final diagnosis for those patients. The cardiac MRI is also better in terms of evaluating systolic function, LV wall thickness, the volumes in the right ventricle and the left ventricle. It's also important to assess inflammation and fibrosis. And another important tool from the cardiac MRI is the late gadolinium enhancement. So late gadolinium enhancement is now known to have a significant importance in terms of prognostication. We know that there is a direct relationship between the extent of the late gadolinium enhancement and worse outcomes, including sudden cardiac death. So the late gadolinium enhancement also is not only for prognosis, but also for diagnosis. If we have an extensive subepicardial late gadolinium enhancement, this is very characteristic of myocarditis, for example. So the pattern of the late gadolinium enhancement is going to give us important clues to achieve a proper diagnosis. If you have, for example, a diffuse subendocardial late gadolinium enhancement, you can think about cardiac amyloidosis. If you have a low T1 mapping, it's very characteristic of Anderson Fibers disease. If you have also posterolateral late gadolinium enhancement, is also characteristic of Anderson Fibers disease. If you have abnormalities on the T2 weighted mapping, it's very characteristic of hemochromatosis. So it's important to understand the pattern of the late gadolinium enhancement to try to achieve a proper diagnosis. And the cardiac MRI, like I said, is important for diagnostic, prognostic, and to evaluate the progression of the disease and the benefits, the responsiveness to therapy. There are some contraindications like GFR lower than 30 or previous history of metal implants, but we now know that there is a type 2 gadolinium that can be used in patients with renal dysfunction. In terms of genetic testing, this is another important investigation that we should do on these patients. Previously, several forms of cardiomyopathy that were considered to be secondary to external factors like toxic, chemotherapy-induced, were recently proved to have genetic contributors to it. So we know that now patients that present with alcohol-induced cardiomyopathy, 13% may have a genetic mutation. In terms of peripartum cardiomyopathy, they found that there are variants in 8 different genes that can be associated with peripartum cardiomyopathy, and it accounts for 15% of the women with this diagnosis. Also, myocarditis patients may have genetic abnormalities, and 8 to 22% of those patients may have variants. And when they analyze patients with HCM and LVH phenotype, doing like a screening genetic test, they found that 0.9% of those patients have had Anderson Fibers disease. How is the genetic architecture in cardiomyopathy? Is very heterogeneous. So patients may have different variants, different genes causing the same phenotype. So it's very heterogeneous. And we not only find the usual Mendelian form of inheritance, but we can also find polygenic forms of inheritance. So patients may present with different phenotypes, different clinical presentations, and they can have different variants and mutations. Why should we do genetic test? For the patients, it's important for diagnosis, prognosis, because we know that there are some genetic mutations that are associated with worse prognosis and sudden cardiac death. Therapy, because in those patients that we, for example, know that they have worse outcomes, a genetic form that predisposes sudden cardiac death, we're going to have a lower threshold for ICD insertion, and is also important for reproductive counseling. For the relatives, it's important to know if they are carriers of that genetic variant, and they would need to be followed closely. So the genetic test should be done in everyone that presents with cardiomyopathy, regardless of the age, and even if it's not going to change our management. So when you identify a patient with cardiomyopathy, you have always to ask about the family history to try to find if there is any indication of Mendelian inheritance. These patients should have a pre-test and post-test counseling with a genetic counselor. And after you do the genetic test, you need to interpret the results and decide about the family screening. What are the common results that we find? So you can find a negative test, which it's not it doesn't mean that the patient doesn't have a genetic disease, but it means that you couldn't find a variant in that specific gene that caused the cardiomyopathy. It can have a variant of uncertain significance, which is an inconclusive test, meaning that you did find a variant that is associated with a gene, but you don't know if that variant caused the disease. And you can find a positive test when you find a variant that has been found to be associated with disease. When you find patients with a variant of uncertain significance, these patients should also be referred for counseling. And you should repeat the test in 3 to 5 years, because it doesn't mean that this variant is not going to change the significance in the next years. So a variant of uncertain significance can be interpreted as pathogenic in the next 5 years, or it can be interpreted as benign in the next 5 years. Who should have a genetic test? Like I said, every patient that presents with a cardiomyopathy, non-ischemic cardiomyopathy, should be offered a genetic test, regardless of the age and regardless of if this is going to change the management or not. And this is now a class 1 indication. In terms of the family screening, when the patients have the clinical presentation and the positive genetic test, we need to screen all the first-degree relatives of that patient, do a clinical screening with ECGs and echocardiogram, and also do a cascade genetic testing if you do find a variant that caused the disease. Extracardiac features are very important in terms of finding the proper diagnosis. And we need to look very careful in all of those patients to try to find other clues for the diagnosis. So, for example, if you see a patient with an HCM phenotype that has bilateral carpal tunnel syndrome, you may think that this patient can have cardiac amyloidosis. If you see a young patient with an HCM phenotype presenting with angiokeratomas, a stroke, and proteinuria, you will think about Anderson Fabry disease. If you see a patient with developmental delay, you can think about mitochondrial diseases, Noonan syndrome. So the extracardiac features are very important to give us clues of possible diagnosis. What are the general principles in the management of cardiomyopathy? So we know that if the patients present with heart failure, there is now medications that can reduce mortality when talking about patients with heart failure and reduce TF. We know the guided medical therapy, the quadruple therapy, can reduce mortality in these patients. For the patients that present with HFpEF, we don't have until now, we don't have a medication that actually reduce mortality, but we do have medications that reduce significantly hospitalizations. And the recent guidelines, the ESC guidelines, are now indicating SGLT2 inhibitors as class 1 indication for treatment of HFpEF. So this is the only medication that we have as a class 1 indication that can actually reduce hospitalization. In terms of atrial fibrillation, it's very common to see atrial fibrillation in patients with cardiomyopathy, especially in patients with HCM and restrictive cardiomyopathy, because they have the concept of atrial disease as well. So for these patients, we always anticoagulate. For patients with dilated cardiomyopathy, ARVC, and non-dilated LV cardiomyopathy, you can use the Shad's-Vest score to decide for anticoagulation. It's important to understand that we should always try to keep these patients in sinus rhythm, and because we know that this concept of atrial disease, these patients, they can reduce cardiac output if we don't keep them in sinus rhythm. So a rhythm control strategy, when possible, is always preferred. And there is also specific therapies for some of the conditions that I'm going to talk about in the next slides. We have new treatment for HCM, we have new treatment for amyloidosis, we have treatment for Anderson-Fabry disease, we have treatment for hemochromatosis. So that's why it's very important to achieve the correct diagnosis. In terms of ICD recommendation, I'm just going to mention generally because depending on the etiology, there is a different recommendation for ICD. So basically what we need to understand is that the ICD is recommended to increase survival. So we need to think about ICD for patients that will have a life expectancy greater than 1 year. And it's also a decision sharing process with the patients and with the healthcare team. So the general recommendation for secondary prevention, ICD is always recommended. If the patients presented or survived a cardiac arrest or had evidence of VT, the ICD is recommended as secondary prevention. For primary prevention, it will depend on the etiology of the condition. So we know that for patients with HCM, there is a risk calculator score. And depending on that score, we're going to decide with the patient regarding the ICD insertion. And this score is based on findings on echocardiogram and cardiac MRI. So for example, extensive late gadolinium enhancement, an LV dysfunction, presence of LV aneurysm, increased LA size. So these are all features that are present in this risk score that we need to calculate in order to indicate an ICD. Same thing for arrhythmogenic right ventricular cardiomyopathy. There is a specific risk score to determine if those patients will need an ICD. For dilated cardiomyopathy, we usually indicate an ICD when the EF is lower than 35% on patients that are on optimized guided medical therapy. So this is the basic recommendation. And for some genetic mutations, specifically on the LMNA gene, we know that we would have a lower threshold in terms of ICD recommendation because this genetic mutation is associated with worse outcomes. So talking a little bit about HCM is the classic HCM is an autosomal dominant condition where we have an LV hypertrophy. It's associated with sudden cardiac death, and these patients will present with an LVOT obstruction gradient, and this is what causes symptoms, specifically on exertion. It can manifest as preserved EF, and with the progression of the disease, they can present reduced EF at a later stage. Important to note that there's also the non-familial HCM. These patients usually present with not severe symptoms. They are older. They don't have significant LVOT obstruction. They have lower gradients. But just to keep in mind that we have this non-familial HCM as well. So even in an older patient, you can suspect of HCM. For the patients with HCM, like I mentioned before, there is an overlap between phenotypes. So the multimodality imaging is very important because it's going to give us some clues in terms of the diagnosis. We know that there are the HCM mimickers with so patients that present with an HCM phenotype, but they actually have another etiology like Anderson-Fabry disease, amyloidosis, hemochromatosis. So it's very important to perform a cardiac MRI to understand if this is the classical sarcomeric HCM or this is a secondary cause of LV hypertrophy. In terms of management of HCM, patients will present with dyspnea on exertion. When you do an echocardiogram or an echo stress, there is an increased LVOT gradient, and when greater than 50 in patients being very symptomatic is when we should start treating those patients. Initially with beta blocker, if the symptoms persist, we can add calcium channel blockers like verapamil or diltiazem. We can also add disopyramide. And if the patient is still symptomatic in NYHA class 2 or 3, despite all these medications on high tolerated doses, we have this new medication called mavacamten, which is a cardiac myosin inhibitor. So this medication is recommended for these patients that persist with an increased LVOT gradient and are still symptomatic despite being on the other medications. And this was proved on the Explorer-HCM trial that randomized patients to mavacamten or placebo. And they noticed that the patients on mavacamten had a significant reduction in the post-exercise LVOT gradient. They had also a significant reduction in the resting LVOT gradient. Also significant reduction in NT-proBNP levels. So this medication, it doesn't improve mortality, but it does improve quality of life and reduce the LVOT gradients. If the patients are not candidates for mavacamten, or if they present side effects with mavacamten, we also have invasive therapies. And these patients can be assessed for myectomy or alcohol septal ablation, and this will be decided by the intervention team which of those two strategies is better for that specific patient. Dilated cardiomyopathy, so the presence of LV dilatation with systolic dysfunction. 40% of the cases, the patients will have a genetic abnormality associated with this phenotype. And there are more than 50 genes that have been associated with dilated cardiomyopathy. Different etiologies. It could be viral infections, bacterial infections, toxic, alcohol-induced, chemotherapy-induced, peripartum cardiomyopathy, autoimmune diseases. So there is a variety. The etiologies that are, the number of etiologies are very high. ARVC is characterized by the myocardial atrophy and fatty deposition, fatty replacement on the RV myocardium. We know that this phenotype is associated with worse outcomes in terms of ventricular arrhythmias and sudden cardiac death. Sure. And for the diagnostic criteria, there is a specific criteria that includes ECG changes, the presence of ventricular arrhythmias, the presence of a genetic abnormality, specifically on the desmosomal gene protein. And I wanted to talk a little bit more about the restrictive cardiomyopathy. So this type of cardiomyopathy, like I said before, is characterized by this restrictive physiology where you have high ventricular filling pressures. Due to this stiff myocardium, it's usually present in patients with filtrative diseases or storage disorders. Initially present with HFpEF, but with the progression of the disease, they can present with heart failure and reduce the F. So, like I said before, this phenotype usually overlaps with HCM phenotype. So it's very important to understand the physiology, and the MRI is also important in this evaluation. There are different causes for restrictive cardiomyopathy. We have storage disorders like hemochromatosis, Anderson Fibro disease, Danon disease. We have infiltrative etiologies like amyloidosis, sarcoidosis. So there's also a big list of possible etiologies for this phenotype. And I wanted to talk about cardiac amyloidosis because it's one of the etiologies that we do have treatment that reduce mortality. The cardiac amyloidosis was previously underdiagnosed, but now we have seen more and more patients with this condition because we are diagnosing them earlier. In previous autopsy studies, it was shown that 25% of patients older than 80 years old, they had TTR depositions in the myocardium. The pathophysiology of this condition is basically the deposition of misfolded proteins in the myocardium, and is considered an infiltrative cardiomyopathy. The two main types involving the myocardium are the immunoglobulin light chain, the AL amyloidosis, and TTR amyloidosis. And the TTR amyloidosis is classified in hereditary and wild type. And this classification is based on the genetic test. What are the clinical features? So patients who present with heart failure, atrial fibrillation, they can present with AV block, ventricular arrhythmias, and low-grade, low-flow aortic stenosis. It's also important to understand that these patients have extracardiac features. So if you see patients that present with bilateral carpal tunnel syndrome, or they have previous history of spinal stenosis, these are common extracardiac features in this population. Autonomic disorder with orthostatic hypotension, proteinuria, GI symptoms, these are all features of cardiac amyloidosis. When do we suspect of cardiac amyloidosis? We see a patient with an HCM phenotype. Is that phenotype related to hypertensive cardiomyopathy? Is that HCM phenotype related to aortic stenosis? We need to have other clues to try to find the diagnosis of cardiac amyloidosis. So patients, like I said before, that had previous history of bilateral carpal tunnel, peripheral neuropathy, spinal stenosis, spontaneous biceps tendon rupture, you can think about amyloidosis. Patients that present with persistently elevated troponin levels on the blood work, you can think about amyloidosis on those patients as well. Patients that have aortic stenosis, severe aortic stenosis, but low flow, low gradient, you may think about cardiac amyloidosis. And these patients usually do not tolerate beta blockers, ACE inhibitors. They have also autonomic dysfunction. They present with dizziness, orthostatic hypotension. So these are features of cardiac amyloidosis in which patients you could suspect of amyloidosis. So what is the diagnostic pathway? After you find a phenotype, you suspect you found extracardiac features, you suspect of amyloidosis, you need to understand if there is, you need to screen for plasma cell dyscrasia. And how do we do this? We check on the blood work. We do a monoclonal protein study, including serum and urine protein electrophoresis, measurement of serum-free light chains, kappa and lambda light chains, and kappa and lambda ratio. If these patients present with an abnormal kappa lambda ratio or the presence of protein M on the electrophoresis, you need to suspect of AL amyloidosis. And these patients will need an urgent treatment, which is chemotherapy, and they will need a referral to hematology. If they present a normal SPEP, a normal kappa lambda ratio, then you can think about TTR amyloidosis and you proceed with a pyrophosphate scan. And if positive, you proceed with a genetic test to understand if this is hereditary or wild type. For the treatment, we have specific treatments for patients with hereditary TTR. These are TTR RNA silencing that prevents the production, the hepatic production of those proteins. And this is the medications are inotersen and patisiran. Usually, we use this medication for patients with hereditary TTR and polyneuropathy. For patients that have myocardial involvement and TTR amyloidosis, we use now a disease-modifying therapy, and the name of the medication is tafamidis. So this medication has proven to reduce mortality significantly and reduce hospitalization in this trial that randomized patients to placebo or tafamidis. And they noticed a 32% reduction in mortality rates and 30% reduction in hospitalization. In terms of other recommendations for those patients, exercise. So we know that cardiomyopathies are the leading cause of exercise-related sudden cardiac death in young population because of the increased concentrations of catecholamines, increased cardiac loading. So we should recommend exercise for patients, but with some restriction restrictions in some cases. So, for example, for patients with HCM, if the patients have low-risk features, no alveolar obstruction, normal cavities, no symptoms, you can recommend high-intense exercise. They can participate in competitive sports, and you don't need to do any restrictions. Of course, if patients are symptomatic and they have an increased LVOT gradient, you're not going to recommend high-intensity exercise. If the patients present the genetic abnormality, but they don't have the phenotype, you can also give a recommendation for high-intensity exercise. For ARVC, we do not recommend high-intensity exercise because we know that this is associated with sudden cardiac death. So we usually restrict the exercise for this type of patients. If they have the genetic mutation, but they don't have the phenotype and they don't have symptoms, then you can recommend mild to moderate physical activity for these patients. And in terms of dilated cardiomyopathy and non-dilated LV cardiomyopathy, patients that have no symptoms, they can participate in most competitive sports and high-intensity exercise. It mostly depends on their symptoms. We just have one type of patients, one of the genetic mutations, LMNA, that is associated with sudden cardiac death. So in these patients, we should give some special considerations in terms of exercise. So the diagnostic approach, the treatment of patients with non-ischemic cardiomyopathy needs to involve a multidisciplinary team for patient support. So cardiologists, nurses, psychologists, genetic counselors, electrophysiologists. So there's a multidisciplinary team that needs to be involved in the care of these patients. And in summary, what I wanted to highlight in this presentation is that it's very important to achieve definitive diagnosis for patients with cardiomyopathy. And this includes classifying those patients according to the phenotype and observing also their extracardiac features to try to achieve this definitive diagnosis, because we have now specific treatments for some of those conditions to reduce mortality and improve quality of life. And in the diagnostic pathway, to understand the phenotype and to understand the etiology, it's very important to describe morphology, function, and tissue characterization using multimodality imaging, where the cardiac MRI is an essential tool to give us information about diagnosis, prognosis, and responsiveness to treatment. And also genetic tests that should be offered to all patients with cardiomyopathy, because we know that their pattern of presentation is very heterogeneous. They can have the Mendelian form of inheritance, but they can also have a polygenic form with different genes, different mutations causing different presentations. So the genetic test should be offered for all the patients with non-ischemic cardiomyopathy, not only for diagnosis, but also for prognosis, in terms of understanding if they have worse outcomes, and in terms of therapy as well, because those patients with worse outcomes, we would have a lower threshold, for example, for ICD recommendation. So that's was what I wanted to present. Thank you for your attention, and I'm happy to answer any questions.
Thank you so much, Dr. Borjaille, for this comprehensive overview and depth of knowledge on non-ischemic cardiomyopathy. Last time I learned about cardiomyopathy, non-ischemic was either alcohol or otherwise. People can hear me? Okay, I think I have a problem here. Or let's try this. People hear me? Just want to make sure.
Sorry, I can't hear you.
Can you hear me now? No? Oh, I can't be heard. That's weird. Okay, well, okay, I will let.
Yes, we can hear you, Dr. Khaled.
Or you can hear me?
Yes, clear and loud.
Okay, perfect. Go ahead. You have a question, Dr. Ahmed, right?
Yeah. Actually, thank you, Cristiana, for your lecture. It's a very heavy meal for non-ischemic cardiomyopathy. Do you hear me, Cristiana, or not? It does seem that Cristiana is not hearing me.
Oh.
So.
Oh, yeah, she is having a technical problem, clearly.
Right.
Khalid, maybe you wanna
I can write down. Maybe? I can write down the question for her. Which.
Sorry, I'm not being able to hear, so I'm going to try to answer the questions on the chat.
Yeah, for people, everyone enter, like if you have a question, we're sorry for the technical problem, but if you have a question, please put it in the Q&A section or write it in the chat. So Dr. Borjaille can respond to. I'm not sure if
yeah, I don't know if I stop sharing and try to enter again in the meeting. Okay, there was a question about myocardial biopsy. We don't do it usually unless you don't find a proper diagnosis with multimodality imaging, extracardiac feature genetic test, because it's an invasive procedure. There are complications associated, but I know that sometimes is necessary. So I would recommend a cardiomyopsy if it's the diagnosis is still inconclusive. We have some patients, for example, that is difficult to define if they have AL amyloidosis or TTR amyloidosis, and then the endomyocardial biopsy is a definitive diagnosis. So I would keep this the biopsy for patients where you cannot find a proper diagnosis or if everything is still inconclusive.
Perfect. Thank you. I'm finding a challenge in the chat as well, so I'm not sure if others are. If you want to try to type your questions in the Q&A, would be great.
Yeah, so genetic testing is available at the Hamilton General Hospital. We can do in the hospital lab. There is a specific form that goes for CHIO. They do in Ottawa, sometimes in US, but it's available for anyone. Just do the specific form, order on Epic, and the patient can go to the Hamilton General Hospital lab and do the blood work. In terms of amyloidosis, we have at the Heart Function Clinic some kits for buccal and saliva, which, because genetic tests can be done either blood work, it can be done on saliva or buccal swab. So we have some kits at the Heart Function Clinic that we can send. Interestingly, all these companies that we do for cardiac amyloidosis, this buccal swab and the saliva test, when the test comes back positive, meaning that these patients have hereditary TTR, then they also provide the genetic counseling, and they provide the kit for the family members that need to be tested. So it's available. We usually do for patients that present with non-ischemic cardiomyopathy. Yes, we are doing a lot of genetic tests at the Heart Function Clinic.
Okay, that's perfect. And I know there is technicality here because I'm not seeing any questions. People can also text me their questions directly, and I'll make sure that Dr. Borjaille have them. We have a few more minutes. I don't know if that's going to work.
So there was a question about mid-cavity LV obstruction in HCM. So mavacamten is not approved yet for mid-cavity LV obstruction or cases that are non-obstructive HCM. There are some trials going on for patients with mid-cavity obstruction, but at this moment, mavacamten is approved for patients with LVOT obstruction and NYHA class 2, 3 that persist with symptoms and increased gradients despite being on high tolerated doses of beta blockers, calcium channel blockers, or disopyramide. Yeah, mavacamten, no improvement in mortality. So there was a question about mavacamten being improving symptoms and quality of life in HCM, but no improvement in terms of mortality and prognosis. Yes, no improvement. Either the other therapies, for example, myectomy or septal ablation, none of these treatments improve mortality in HCM. They do improve symptoms and quality of life. I can't see any other questions on the chat. I'm not sure if... Let me see if there are any other questions here. Okay. If we are using, there's another question here. If we are using same management of HCM with cases of non-LVOT obstruction, such as mid-cavity. Yeah, so we are not using mavacamten yet for mid-cavity LV obstruction. There are some trials going on right now for this type of population, but for now it's only approved for LVOT obstruction and in patients with symptoms despite being on medical therapy.